Introduction. Knee pain is a common problem that affects the elderly. But knee injury is not an issue restricted to just older adults. Our knee is prone to risk of injury more than any other joint in the body, apart from the age-related wear and tear. At times, the knee becomes so severely damaged that the doctor may suggest a knee replacement surgery. Before we see how knee replacement surgery is done, let us understand the anatomy of the knee and circumstances under which this surgery is suggested. Anatomy of the knee. Let us see what a normal knee joint looks like. The healthy knee joint is formed by the top of the shin bone, called the tibia, and the bottom of the thigh bone, or femur. The kneecap is called the patella. The joint is supported by cartilage, which serves as a cushion between the bones and helps assure an effortless, smooth, gliding movement of the joint. A special membrane, called the synovial membrane, produces a lubricant that contributes to the smooth movement of the knee. When there is erosion of the joint due to cartilage wear, the knee is unable to effectively cushion the body from impact and stress, and there is a lot of pain. This happens in arthritis or osteoarthritis. The doctor treats the symptoms of pain and stiffness, but cartilage degeneration cannot be treated. In such severe cases, doctors may advise total knee replacement surgery. More than 90% of individuals who undergo total knee replacement experience a dramatic reduction of knee pain and a significant improvement in the ability to perform common activities of daily living. Initial tests before surgery. Once you have decided to go in for TKR surgery after consultation with your doctor, you will have to go through some preoperative tests. These are blood work, urine test, a complete blood count, CBC, may be suggested to check for infection. Since there may be need for blood transfusion during or after the surgery, blood tests will be done for blood matching. ECG, to check heart condition before the surgery. Chest X-ray, to check respiratory status. Consultation with anesthesiologist. TKR is either performed under a general anesthesia or under a spinal type anesthetic. In general anesthesia, the individual is asleep during the procedure. In cases where a spinal anesthetic may be used, an injection is given into the spine, numbing both legs. The individual is conscious but comfortably sedated. Besides, there are other instructions you must follow regarding eating and drinking before the surgery, and a list of medications prescribed to be taken or discontinued prior to the surgery, as per instructions from your doctor. Surgery. Prior to the surgery, the patient is given anesthesia and prepared for surgery. An incision approximately 8 inches in length is made on the front of the knee. Up to 3 bone surfaces may be replaced in total knee replacement. The lower ends of the femur. The lower end of the thigh bone, or femur, is resurfaced with a metal cap. The metal femoral component curves around the end of the femur, or thigh bone. It is grooved so the kneecap can move up and down smoothly against the bone as the knee bends and straightens. The top surface of the tibia. The upper end of the leg bone, or tibia, is replaced with a plastic and metal implant with cement and/or screws. The implant is a flat metal platform with a cushion of strong, durable plastic called polyethylene. Some designs do not have the metal portion and attach the polyethylene directly to the bone. For additional stability, the metal portion of the component may have a stem that inserts into the center of the tibia bone. The back surface of the patella. The back of the kneecap, or patella, is also resurfaced with an all-plastic implant. Highly specialized instruments are used that allow precision cutting of the bone so that the new joint fits perfectly. The type of implant used depends on the surgeon's preference and patient requirements. The patellar component is a dome-shaped piece of polyethylene that duplicates the shape of the patella, or kneecap. Components are designed so that metal always adjoins with plastic, which provides smooth movement and results in minimal wear. Sometimes, depending on the surgeon, the back of the kneecap is left intact if it is not badly affected by the arthritis. The surrounding muscles and most of the ligaments are preserved. Recovery in the hospital. The first day you can expect a clear liquid diet, an intravenous line in the arm for fluids and antibiotics, pain medication by injection or intravenously or as tablets, blood transfusion if necessary, activity as tolerated to include walking, full weight bearing if a cemented knee was used, and toe touch or limited weight bearing if an uncemented knee was used. Breathing exercises. The second and third day you can expect initiation of exercise program. The fourth day to 1 week you can expect progression of walking and exercises. Instruction on how to dress, get in and out of bed, and utilize the bathroom safely. Post-operative rehabilitation. Protected weight bearing on crutches or a walker is required until the quadriceps muscle has healed and recovered its strength. Patients typically undergo several weeks of physical therapy to restore motion, strength, and function. Often, range of motion to the limits of the prosthesis is recovered over the first 2 weeks, the earlier the better. At 6 weeks, patients have usually progressed to full weight bearing with a cane. Complete recovery from the operation, involving return to full normal function, may take 3 months, and some patients notice a gradual improvement over some more months. Routine activity. Getting back to routine activity, needless to say, will happen gradually. Most patients are able to resume driving by about 4 weeks after surgery. It depends upon your leg positioning, strength, and coordination. Before you start, check with your surgeon. Take good care in the post-operative period and follow physical therapy to help recovery.